Okay, all right. So welcome everyone. My name is Amy. I'm one of the hematologists in Halifax, Nova Scotia. I also do thrombosis, and today I'm going to be the moderator for this CanVector National Thrombosis Seminar. So these are monthly seminars that are hosted throughout the academic year, and they feature state-of-the-art thrombosis and VTE lectures that are presented by both Canadian and international experts. The recordings are available after the event on the CanVector website, and also the seminars are a self-approved group learning activity by the Royal College of Physicians and Surgeons of Canada. And so you can submit that for a mock credit. So I have the pleasure to work with these lovely committee members on planning the different seminars throughout the year. The committee is chaired by Dr. Joseph Shaw. And today's presentation is shining a spotlight on invisible minority groups incorporating EDI in VTE research design and implementation. So we're very lucky to have two wonderful speakers today. We have Dr. Shova Dawson, who is joining us from the UK. She co-leads the Triage Forge Inclusive Research Centre in Sheffield, which aims to increase evidence-based for methodologic approaches to improve inclusivity in trials and therefore improving trial design, decision-making, relevance, and generalizability. She also co-leads the GPs at the Deep End Network in Bristol, which aims to reduce health inequalities through peer support, advocacy, training, and research for primary care clinicians who are working in disadvantaged areas. Our second speaker is Dr. Yan Zhu, who's an assistant professor and a Tier 2 Canada Research Chair in thrombosis at the University of Ottawa and the Ottawa Hospital Research Institute. His research aims to summarize the impact of VTE across ethno-racial and ancestral groups, explore the heterogeneity in treatment effects, and address the structural barriers to participation among ethno-racially underrepresented populations. So here are just the learning objectives for today's seminar. And throughout the seminar, there'll be a chat box that you can enter your questions. And at the end of the seminar, we will have 15 minutes for Q&A session. And so fully look forward to your questions during that time.
Sorry, just kind of make sure that it's the right screen I'm sharing. Fantastic. So, thank you very much, Dr. Harrigan, for a kind introduction. And today, it is my pleasure and privilege to share this presentation and the stage with Dr. Dawson and to learn from and to have her expertise. So our topic is going to be a shining a spotlight on invisible minority groups, EDI in VTE research design. And as I stand here in Ottawa, I'd like to begin with Indigenous affirmation. We pay respect to the Algonquin people, who are the traditional guardians of this land. We acknowledge their longstanding relationship with this territory, which remains unceded. We pay respect to all Indigenous people in this region from all nations across Canada who call Ottawa home. We acknowledge the traditional knowledge keepers, both young and old, and we honor their courageous leaders, past, present, and future. For my segment of the presentation, the next 15 to 20 minutes or so, I'd like to illustrate the imperative to improving ethnicity and ethno-racial diversity in VT research and to address the why behind the need for diversifying and to ensure that EDI principles are incorporated in our ongoing VT research efforts. And to do so, we'll first define key terminology such as race, ethnicity, and ancestry and understand their implications for VT research and outcomes, and explore the epidemiological data highlighting disparities in VT incidence, treatment, and outcomes between different ethnic and racial groups and why diversity in VT research matters. So to dive in, Race is defined as a social construct based on perceived physical differences, such as facial features or skin color. So an example, Asian would be a racial category. Now, it's important for us to recognize that there's often conflation between race, ancestry, and biology. However, there is no scientifically supported biological basis for discrete racial group, such that the 4 or 5 racial categories that are most often used in the United States context are not considered to be biological variables. And in fact, genetic ancestral variation within a specific racial category often is more than those between races. To illustrate this point, I'd like to invite you to look at the diagram on the bottom. And this is data that is derived from the 23andMe data analysis by Brick and colleagues that looked at individuals who submitted samples who self-reported as being African American by their self-reported race, and looked at the distribution of genetic ancestry within these populations across different states. And as you can see, among individuals who all self-reported as being African American or Black in their self-reported racial category, a significant proportion due to population mixture, in fact, have European or Native American ancestry. And when you look at the European American population, the converse is exactly true, where a significant proportion, especially those in the southern states, despite being self-reported as being European American, in fact, have a significant proportion with greater than 2% African ancestry or Native American ancestry. And this highlights the fact that genetic variation does not split humans neatly and unambiguously into 4 or 5 distinct racial groups. Now, a related concept to racial groups is the concept of ethnicity, whereby it's defined as groups of individuals who have shared cultural characteristics such as language, diet, nationality, behavior, or religion. So as an example, Korean would be considered an ethnic group. And ethno-racial groups would comprise of both racial and ethnic characteristics. Now, a related concept to ethnicity and race is the concept of ancestry. And ancestry is a biological concept of a set of individuals who shared more similar genetic origins. I invite you to look at the diagram on the right, which is what I find to be quite a nice diagram that separates the concept of race, ethnicity, and ancestry, published by Liu and colleagues from Dr. Sonia Anand's group out of McMaster, and specifically delineating some of the differences between the three terminologies. I'd also like to invite you to look at the bottom right of that diagram, where they implore and emphasize the need for greater ethnic diversity among genetic study populations proportionate to the ethnic group's disease burden. Now, why might that be relevant in the context of venous thromboembolism? Well, what we know been known for a long time is that inherited predictors or genetic thrombophilias pertaining to venous thromboembolism show significant difference between racial categories. This work by Ritker and colleagues published in JAMA in 1997 looked at, in the general population, the carrier frequency of factor V Leiden, which is one of the more commonly recognized inherited thrombophilias. You can see here that there's a roughly 10-fold difference in the carrier frequency of factor V Leiden among European American population compared to Asian American population. Now, while this is interesting, it masks a significant issue with respect to the fact that, as you'll recall, factor V Leiden acts through resistance to the activated protein C pathway as its pathophysiology. And yet, there are other genetic polymorphisms in the factor V gene outside of the European American or European ancestral groups that have similar pathophysiology and similar mechanisms of action that are in fact are not considered to be factor V Leiden. And this is work that was published in 2014 by Nogami and colleagues that identified a new variant known as factor V Nara, identified in Japan, that is associated with venous thromboembolism with more potent efficacy compared to factor V Leiden. And the fact that there is greater phenotypic description of such genetic mutations is crucial in order for us to understand some of these genetic variation across the global scale as we think about differences in genetic diversity and its impact on venous thromboembolism prediction. Of course, beyond inherited thrombophilias, cancer is an important predictor of venous thromboembolism, and the Corona risk score is one of the most frequently used validated risk scores for predicting the risk of venous thromboembolism among patients with cancer who began anti-cancer therapy. You can see here that the original systematic review and meta-analysis of the Corona risk score with 6-month follow-up on the figure to the left by Mulder and colleagues using a predominantly European ancestry population identified the incidence of VTE at 5% among individuals classified as low risk, 6.6% among individuals classified as intermediate risk, and 11% among individuals classified as high risk after 6 months of follow-up. Now, in 2024, just this past year, Shoji and colleagues, using roughly 8,000 individuals in Japan, attempted to replicate the Corona risk score in a Japanese population. And what they identified, despite a longer duration of follow-up, is the fact that there is a significantly lower incidence of VT for the same categorization of the Corona risk score, underscoring the fact that despite the variables that were established in a predominantly European ancestry population or a white population, there's concern that the predictive accuracy of the Corona risk score may not be the same between different ethnic and racial groups. Now, what about treatment-related complications and treatment-related duration? What we know from international guidelines is that long-term anticoagulation after a first episode of unprovoked VT is universally recommended. And this has not changed in the 13 or the 17 years between the CHEST guidelines in 2004 and the CHEST guidelines in 2021 and the American Society of Hematology guidelines, the most recent revision. The data that support this recommendation derives from the fact that among the general population, quote unquote, who suffer a first episode of unprovoked venous thromboembolism, that their subsequent risk of recurrence largely exceeds the 5% threshold in whom indefinite anticoagulation is recommended, and on the contrary, with respect to risk of bleeding or risk of harm, that their annualized risk of bleeding is far below the 3% per year risk in whom anticoagulation would not be recommended. And on the net clinical benefit balance, therefore, long-term anticoagulation would be suggested. Now, while this is certainly true, the populations that were enrolled in these studies were largely European or white in ethnic, in racial or ethnic or ancestral population in origin. And therefore, there's a need for us to understand whether the risk of major bleeding is similar between ethno-racial groups. And so we undertook a study to look at a combined analysis of 2 cohorts, the bleed risk and reverse 2 cohorts that are depicted on the right here, who enrolled patients after initial 3 months of anticoagulant therapy after a first unprovoked venous thromboembolic events, and followed them over time for incidents of major bleeding that were adjudicated either as a primary or secondary endpoint. As you'll see here, we compared individuals who self-reported as being Black versus those who self-reported as being white in their racial category. You'll see here, similar to what I've described earlier with respect to factor V Leiden, that there's a lower prevalence of factor V Leiden or prothrombin gene mutation carriership among Black participants compared to their white counterparts. And on the other hand, there was a higher prevalence of known risk factors for major bleeding, such as anemia, the presence of hypertension, concurrent antiplatelet therapy, and those who are classified as high risk using the CHAP model for anticoagulant-associated major bleeding during extended duration anticoagulation for venous thromboembolism. We determined that compared to their white counterparts, that individuals who self-reported as being Black, who continued on anticoagulant therapy, had a roughly 2-fold increased risk of major bleeding while on anticoagulant therapy, and that their absolute incidence of major bleeding approximates that 3% threshold above which the net clinical benefit of anticoagulation becomes unfavorable. And despite adjustment for these known risk factors for major bleeding, there's remained a statistically significant increase in the hazard of major bleeding among Black participants compared to their white participants, highlighting the need for further research to understand these racial disparities and to provide appropriate risk prediction models, as we identify that even among individuals with low risk of bleeding as classified by the CHAP model, that Black participants continue to have a near doubling of the incidence of major bleeding compared to their white counterparts. And again, that risk incidence approximates that 3% threshold above which ongoing anticoagulant therapy becomes unfavorable. Now, what we recognize is that ethno-racial diversity remains suboptimal in most trials of investigational agents. In a cross-sectional analysis of 261 new molecular compounds approved by the FDA in the United States, approximately 1 in 10 had known differences in pre-phase 3 studies in exposure or response across ethno-racial groups or pharmacogenetic factors that vary by global populations, such as CYP polymorphisms. Nonetheless, compared to the general US population and the distribution of racial ethnic categories within the US general population is depicted on the top right of this slide, enrollment of ethnic and racially underrepresented populations remains suboptimal, especially among African American or Black populations, as well as those of Hispanic or Latinx ethnicity. VTE is no exception to this observation, whereby no global phase 3 VTE trial recruited over 30% of participants who are non-white in race, and that enrollment of Black or Hispanic populations were consistently less than 5%. And this is not because of the population burden of disease, and that the only studies enrolling greater than 30% of non-white participants were in Japan due to regulatory requirements for market authorization. As I mentioned, the under-recruitment of African American or Black populations in VT research is not due to burden, is disproportionate to burden of disease. As you can see, the incidence of VTE, as depicted in cells in red, are significantly higher among Black and African American populations in the United States context compared to their white counterparts. And therefore, the need to ensure inclusive participation in VT trials that are proportionate to the disease burden experienced by racialized populations is paramount. Now, so far we talked a lot about biological and ancestral diversity, but it's important for us to recognize at the same time that there is underrepresentation of ancestral diversity and genetic diversity in our ongoing genome-wide analysis studies that contributes to things like variants of unknown significance for a variety, for many mutations that are not phenotypically characterized among ethnic and racially underrepresented populations. There is intersecting social and economic factors that need to be recognized, and by underrepresentation of racialized communities are lacking in our disease understandings of mechanisms and intervenability to ensure equitable outcomes among racialized and ethnic and racially underrepresented populations who suffer from VTE or at risk of VTE. And that this ties into our intersectionality framework, where race and ethnicity are but two variables within a host of other variables, socioeconomic, such as language, education, religion, culture, geography, and others that can together be mitigative or additive with respect to the disease burden of VTE and its treatment complications. So to understand and to be able to tease apart these intersecting data and these intersecting groups of individuals and the mechanism through which these intersecting powers and these intersecting factors, in fact, exert their impact on outcomes, the future is in disaggregated data. And the concept of disaggregated data is quite well known and quite publicized in lay media as well as in academic literature. Now, nonetheless, it's important for us to recognize that despite the quote-unquote emphasis on EDI principles and the need for inclusivity within our clinical trial infrastructure, there's ongoing need for further work in this realm. And this is data from, a report from the American Society of Hematology at their annual meeting just in December that highlighted through surveys and focus group that there remains little integration of DEI principles in existing clinical trials in the field of hematology, and that there's a need for ongoing actionable recommendations that are needed by our trial sponsors and investigators. And these 8 recommendations were made, including harmonization of demographic terminology and data collection, engagement of lived experience experts from study start to dissemination, improved awareness of how implicit biases impede patient enrollment, the need for REBs to uphold the justice principle of clinical trial enrollment, broadening eligibility criteria so fewer people are excluded from trial participation, expanding access through decentralized trial design, improving access to clinical trial information, and increased involvement of community physicians in the clinical trial ecosystem. And Dr. Dawson, I'm sure, will get into more of the practical and important recommendations to provide the actionable step. Now, an example of this with respect to venous thromboembolism is in the realm of heavy menstrual bleeding among women. In the post-marketing studies, it was noted that heavy menstrual bleeding is a commonly seen complication among women, especially those on anti-10A inhibitors. And this finding only came about in the post-marketing setting because of underreporting of heavy menstrual bleeding among women in the regulatory trials, in the phase 3 trials that led to the drug's approval. Now, with newer novel compounds such as factor 11 inhibitors and factor 11(8) inhibitors being now tested in phase 3 trials, it is observed that we're perhaps making the same mistakes again, with specifically heavy menstrual bleeding not being incorporated as an important clinical endpoint, a complication that disproportionately affect women. And so really, this is, again, is an example of the need for us to do better with respect to integration of EDI principles, not only within ethnic and racialized minority populations, but across all underrepresented populations. Nonetheless, despite all the challenges, we recognize that change is coming. Health Canada has recently released a draft guidance on the collection analysis of disaggregated data in clinical trials, including racial and ethnic disaggregated data through heterogeneity assessment, disaggregated data plan, and disaggregated data submission. And this is going to be required step forward for regulatory approval. And FDA has already taken a step ahead in their snapshot, which is the public-facing document that they release that provides snippets of their regulatory approval documents and their clinical review on disaggregated data by sex, race, and age. And so change is coming, and further change is needed in order for us to improve the diversity and inclusion with respect to VTE research. So to summarize, race, ethnicity, and ancestry are interconnected but distinct concepts. And the underrepresentation of ethnic and racialized minority groups in VTE research results in biased risk prediction that do not account for risk factors that are unequally distributed across racial, ethnic, and ancestral populations. Patients enrolled in contemporary VTE trials do not reflect the racial and ethnic differences in disease burden. And that most importantly, responsible collection and reporting of disaggregated data will pave the way to understanding and addressing disparities in prevention, diagnosis, treatment, and prognosis of VTE. I thank you for your attention, and I'd like to pass the mic over to Dr. Dawson.
Can you see my slides okay? Yeah, excellent. Thank you so very much, Jan, for the opportunity to be here today and present as well. Really appreciate it and really excited to share this space with you all. So what I'm going to be doing today is essentially taking you through and providing you with a brief overview in terms of the state of trials and ethnic diversity, what's happening specifically in the UK from the funder and the regulatory perspective, and also showcase some examples of inclusive approaches and how I have implemented this in research, followed by some frameworks that have been developed in the UK. So just to give you a bit of an overview as such, you'll know that specifically in the UK, South Asians are the largest ethnic minority groups. They also tend to have poorer outcomes as far as type 2 diabetes and other conditions are concerned. They are also disproportionately affected specifically by type 2 diabetes as such. A systematic review, so this is a slightly older one, so prior to the 2020s census data really. What this review found was they included 12 studies from the UK, and the mean South Asian involvement was only 5.5%, despite South Asians representing 11.2% of the UK type 2 diabetes population. 4 of the 12 studies did not even report on ethnicity as such. So essentially, again, a great example to showcase that they don't necessarily cater to the segment of population. They only cater to a particular segment of population and they exclude others. So similarly, during COVID-19 pandemic, we all know that there is underrepresentation of ethnic minority groups in COVID-19 research, including those for randomized controlled trials of potential treatments and vaccinations as such. And despite greater burden, what this review found was only 6 of the 1,500 studies that were registered on clinicaltrials.gov were collecting any data on ethnicity. And 5 of the 207 articles identified through database searches reported on ethnicity, and 12 of the 690 articles identified from top-tier medical journals reported ethnicity. Again, it goes to show that right from the design stage, we have problems, and therefore we are baking in inequalities from the very beginning as such. Thinking about a UK example particularly, we conducted a systematic review. So we had an MSc student, so myself and my colleague Sangeeta worked with Julia, our student, to do the systematic review wherein we looked at UK cardiovascular trial protocols to identify what proportion of eligibility criteria may disproportionately exclude people from ethnic minority groups as such. What we found was we identified 70 protocols for inclusion. Almost 87 of them mention consent within eligibility criteria, and with more than 2/3 of them indicating a need for written consent. Therefore, any alternative consent pathways such as verbal consent or recorded consent were completely absent. English language was also a requirement in almost 23% of the studies, and 37% of it featured broad criteria that was open to interpretation and subject to recruiter bias, and only 4%, so that's 3 of the 70 protocols, mentioned any provision of translation services as such. So again, this is a classic example that goes to show that we often do not think about how what we are doing will benefit society as a whole as such. And we often, don't necessarily cater to the wider population, which means that, again, we are starting to perpetuate inequalities even more. And it's quite important to remember that in order to make any sort of meaningful strides towards inclusion, ethnicity has to be considered alongside other intersecting identities. So accounting for intersectionality, which Jan has already talked about, that often, because these intersecting factors often create social disadvantage. And in order for equitable trials, we need to think about eligibility criteria that are placed within the larger inclusive framework of recruitment as such.
Dr. Dawson, you're on presenter view. We can see your notes, so I think we just need to
No,
switch.
that's absolutely
Sorry.
fine. Sorry. I have had problems sharing. 1 second. Because the screen is not showing me what I wanted to show. Bear with me, please. Let me stop and restart. Is this better?
That's perfect.
Does this work or does it still cause problem?
It's good on my end.
Yeah, okay, thank you. Right, so thinking about inclusion as a funder requirement, our NIHR, which is the National Institute for Health and Care Research, which is your equivalent for Canadian Institute for Health Research, is our largest funder of publicly funded trials as such, and also the biggest public funder here in the UK. They have recently made inclusive research design a condition for NIHR funding as such. Similarly, we have the HRA and MHRA, which is the regulatory body. So Health Research Authority and the Medicines and Healthcare Products Regulatory Agency. And they have come up, similar to the FDA, they have come up with an new inclusion and diversity guidance as such. So this particular plan, it's not compulsory for you to complete like the FDA ones. So they specifically focus on 4 key questions as such. So this focuses on who is affected by the disease or condition that is being studied. Question 2 focuses specifically on the aims and design of the findings and whether they are generalizable to everyone at all or not. And question 3 focuses on the recruitment goals. And last question focuses on what the research team's plan of action is to recruit and retain proposed population as such. So what I'm now going to be doing is providing you with an overview of various inclusive strategies that have been implemented in different aspects of the research. So thinking about the research cycle, I'm going to provide you with examples pretty much for all the aspects except for data analysis and interpretation, implementation, and evaluation. Most of the examples that I will be providing you are from clinical trials as such. So the first one is a small study wherein I worked with researchers from University of Oxford and Kiel. This was an arts-based project. We worked with 3 different groups who are traditionally considered to be underserved by research. So I worked with South Asian women in Bristol looking at menstruation and menopause. My colleague at Oxford worked with people who had early onset of dementia. And my colleague at Kiel worked with older people with multiple long-term conditions as such. So we had 2 art students who helped us come up with the lovely artwork that you see here. So the idea of this work was to identify each of these groups' research priorities as such. So we got £3,000 to do this. Now that we have identified the priorities, published findings, so what as such. So what we have since done is we have continued to work with the relevant community, and we secured further funding, close to £200,000 really, to do work on improving communication about menopause between South Asian women and healthcare professionals. So from the work that we did, what we then did was we worked with the same community groups and worked with additional patient and public partners throughout this work really. So from the pre-grant application to them being co-applicants with us, and the idea is that they are now involved in all stages of the study as such. So we are conducting a scoping review, which is nearly done, and we are in the process of completing the qualitative study. Again, they are involved in every step. As far as inclusion for this particular study is concerned, we have ensured that study documentation is available in different languages. So we have recorded the information sheet in audio format in different languages. We developed an easy read version of the patient or participant information sheet. We also have got option for providing verbal consent, and we have reimbursement. Apart from all this, people can also choose whether they want to do interviews or focus groups, and they are available in different languages. We have multilingual researcher who is a part of the study team. And we also additionally have consultant researchers as well in case, we have someone else in the team who doesn't speak that language and we want to recruit participant who only communicates in that language, then we have a backup. In terms of inclusive approach to dissemination, we'll do a workshop report and we'll present this in a graphic format, so similar to that of a storyboard, and we'll also be presenting them as animation. So thinking about the study design as such, in thinking about designing research in itself, my role in various studies is that of an EDI lead, which involves designing plans for increasing diversity in research. So for example, things like providing advice on sample size, identifying relevant languages where we might need translation for, ensuring there is adequate funding for both translation, back translation, raising awareness in local communities about research as such, and also working with community champions to support recruitment, bilingual field workers, etc., and also providing language accommodations, including interpretation. So, for example, let's say that we do not have a clear idea and understanding in terms of prevalence for a particular condition, and assume that it's a multi-site trial that's happening. So here what we will do is we'll recruit participants from ethnic minority groups as a bare minimum based on the census data as such, which at present is 20%. Prior to the 2020 census data, it used to be 13%. So that's an example of how we might go about in deciding how many people to recruit from different groups. So thinking about accessible patient-facing materials, here are a couple of examples that you can see. The one on the left-hand side of the screen that you see is something that we worked with a graphic designer to produce. So it's an easy read version of an information sheet. So it was a little bit more expensive, but we did get each of the pictures done individually, so which means that we can repurpose it and use it in other study newsletters, etc. The one on the right side of the screen that you see is something we developed in-house. Using various stock images, etc., that were freely available to us via PowerPoint. So in addition to all this, we have also developed videos specifically focusing on the clinical trial process. So this is something my PhD student did really. So she was interested in looking at audio recording consent-related discussions. Once we went into the community, we realized that quite a lot of them did not have a clear idea and understanding in terms of how clinical trials worked, what the process entailed, and what a clinical trial is and isn't, etc. So this was something that was requested by the community. So we again worked with the communities, but also with various trialists to co-produce the script of the video, and people from the community have taken part in this. And these are available in 5 different languages. They are available freely for wider use. So if you want to educate your patient partners on what clinical trial is and the process are, feel free to use them. You can also use this to educate potential research participants as such. In addition to all that, we have done information sheets and video formats as well. So for example, this Pfizer-funded study looking at people who have got acute lower respiratory tract infections. So what we did was we identified commonly spoken languages within Bristol. We identified top 10 commonly spoken languages, which were Arabic, Bengali, Mandarin, Polish, Cantonese, Punjabi, French, Somali, Gujarati, and Urdu. So again, we worked with members of various community groups and organizations to develop the information sheets script in those languages, and they also took part in videos. If you click on or if you take a picture of the QR code, you should be able to access them. So one of the things they also requested was that we develop videos on why it is important to take part in research, because quite a lot of them felt that there are so many different types of research. People often aren't, they do not have enough sufficient health literacy to have good idea and understanding or awareness in terms of why taking part in research was important, especially if research doesn't necessarily benefit them to begin with. So we have these, all these co-produced. Again, these are available for you or anyone else interested in this area to use. And we have scripts embedded beneath each of the videos as such, so that if you do not want to look at the video, you then have the script at the bottom to just read off it. So it also caters to those who may have literacy issues as such. Here's an example of an inclusivity intervention. So in case you're wondering how best to embed it in a trial and how to cost that in. So for this particular trial, what we decided to do was focus specifically on how we can address mistrust and also accessibility related issues. So we agreed that we would recruit up to 20 community champions, and we have costed in for 20 hours of their time. Their role would be mainly to raise awareness about the study and support recruitment from few GP practices, and be a point of contact for people to take part. They are also there to support in delivering the cultural competency training as such. We'll have core study team members who will attend the cultural competency training, and then these will be delivered or integrated as part of the site initiation training. And then we have got some money for translation and interpretation as such. So of course, there will be some sites where we will have greater proportion of people from ethnic minority groups living in. So for example, places like London, Bristol, Manchester, etc. There will be other areas where we will have more of pockets of deprivation assets. So for example, thinking about coastal deprivation like Dorset, etc., we'll be recruiting more people from deprived areas as such. Similarly, thinking about dissemination, again, you can either use arts-based approaches or something like this really, which is a storyboard to disseminate findings in accessible formats. I'm going to very quickly take you through the GPs at the Deep End initiative, which was mentioned early on. So the main idea of this initiative is to provide peer support, advocacy training, and research to clinicians and patients working in deprived areas as such. So to give you a bit of an overview, an idea, over 15% of Bristol population lives in most deprived areas of England as such, and where there are considerable health inequalities. So for example, life expectancy for these people are reduced by 9 years in comparison to those living in more affluent areas of Bristol. So we have 17 practices based on the index of multiple deprivation score of 33 or more. The idea is to support them to become research active so that we can then include people who are often missing from research. As part of this initiative, it's also taking that more of that grassroots approach so that we can bring together communities, GP practices, researchers, focus on what actually matters to community rather than us going into communities and saying to them what we think is important. I'm going to quickly take you through some frameworks that exist in the UK, which have been developed. So Include Ethnicity framework is something that was developed just before the pandemic started as such. So this mainly focuses on 4 key questions as such, thinking about what groups you need to think about including in your trial, will people identified respond to the treatment differently at all or not? Will the intervention itself make it hard for some people to be involved in it? And will trial design make it hard for some people to be involved in it? So this essentially gets you to think about inclusion from the get-go, right from the time you are designing the trial all the way through to thinking about rolling it out in practice and then implementation. So they have various worksheets that are available. All this is available for free use, again, via TrialForge website. Again, you should be able to just use the QR code to be able to access it. Happy to share links if it is helpful. So thinking and continuing that thread of who to include. So there is a recent set of recommendations developed by this project called STRIDE, which focuses on supporting the recruitment and retention improvements for diverse ethnicities assets. So here, what it does is it tells you for conditions where you know the prevalence, what you should be doing is, as a bare minimum, recruiting the same proportion of people, who are affected by that particular condition. And for conditions where you do not know the prevalence or it doesn't exist, focus on census data. So again, it gives you what the potential minimum threshold should be in terms of recruiting people from different groups as such. So thinking about how to involve these groups. So the include ethnicity framework tells you some of the things to consider, but it doesn't necessarily tell you how to do these things. So I worked with various trialists who were involved in developing the include ethnicity framework and we also worked with patient and community partners to come up with these 4 key key points or recommendations, if you like. Of course, it is limited. It doesn't really consider things like health literacy, etc. So we are currently in the process of updating this. So it focuses on ensuring that eligibility criteria does not limit participation. Trial materials are developed with inclusivity in mind, ensuring that staff are culturally competent. And the most key important aspect is building trusting relationships with various community groups and organizations. So thinking again about how to collect ethnicity data as such. So there was a project called Included, which focused on inclusivity through improving the practice and utility of ethnicity data collection. So the recommendation that came about from this work was essentially allowing people to self-describe themselves as a bare minimum. And if, researchers are not willing to do that as a standalone question, then make a decision about whether or not it will be useful to have a list of predefined categories which should be used in addition, not as a standalone, but in addition. So they have come up with 13 recommendations. Again, this is available via the TrialForge website, so you should be able to access that as such. Right. So thinking about reporting of ethnicity data as such, just before Christmas, we had this letter published at BMC Trials. So what we were interested in doing was we wanted to investigate what proportion of UK-based RCT publications reported on participant ethnicity. And we looked at 3 high-impact factor journals. So we looked at Lancet, New England Journal of Medicine, and British Medical Journal, BMJ, as such. And we looked at it from Jan 2020 to July 2022. As such, what we found was more than half the studies reported some data on ethnicity, and more than a third of these did not provide any detailed ethnicity breakdown at all. So this basically means they just stated the population numbers or proportion of white groups only, with other groups often combined. And half of these did not even use them in analysis or discuss the significance of it at all, and only over a quarter of it used it in their analysis, and about a fifth acknowledged the lack of ethnic diversity as a limitation in the discussion section. Again, you can see that reporting is pretty poor, to say the least. So thinking about other frameworks that are available. So this is something that is in development. It's a socioeconomic disadvantage framework, which focuses on the 3 Ps based on the UK government child poverty strategy. P refers to pockets, which is linked to the income and economic resource available. Then you have prospects, which is closely linked to the well-being and the life chance, and place, which refers to housing and local environment side of things. So they are currently developing this. They are writing a manuscript at the moment. So hopefully at some point this year it will be published. So that then gives you an idea and indication in terms of how to collect that socioeconomic related data as such, and what sort of question to ask and how to consider them. We also have the impaired capacity to consent framework. That's the website there. And the QR code. They have developed some free training, which is again available through their website as such. And for those of you who don't know, this is the TrialForge website. And under improving trial diversity, you should be able to find all these resources. Thank you for patiently listening to me. And I'm so sorry for the technical glitch. I'm going to stop sharing my screen now.
Perfect. Thank you so much, Dr. Dawson, and thank you so much, Dr. Zhu. So we do have about 10 to 15 minutes for questions. Caleb, I can't seem to see the chat. I don't know if you're the one who sees the chat or not. Or if there are any questions in the chat. Also, feel free to unmute your mic and your camera if you have an in-person question.
I don't have any questions yet in the chat.
Okay, perfect. I guess just to start off, I do have a question for Dr. Dawson. I did think the idea of like having these community champions was really interesting. And I just wanted to know how do you go about like identifying a community champion? Or these patients that or study participants that you've already enrolled in the study and ask them about like an additional, or what process on how to kind of pick them and identify them?
Yeah, so within Bristol, we have something called as health ambassadors. These are different individuals from different community groups who are interested in raising awareness about research specifically. In addition to that, over a 6-year period when I was within the medical school, developed links with and long-standing relationships with 8 different community groups and organizations. So it's through those routes, the idea is to identify potential individuals who can then be trained up and supported to do that sort of role as such. We don't want to blur the boundaries by asking participants to do that. Hence, we have got that role quite separate. So that is something we are trying and testing it out in projects. So it is quite similar to, for example, I know in the States, they have used community health workers. So it's something similar to that. But unlike the States where those roles are clearly defined, we don't have anything like that in the UK system. So this is something you just have to try and test it out to see if it at all works. And of course, I appreciate it'll work for some groups and it might not necessarily for others.
Perfect, thank you. We do have a question from Nicole. So when you talk about self-describing ethnicity without categories, what type of responses do you receive, and how do you synthesize or categorize these?
So that's a great question. Thank you. We have had difficulty getting trialists to actually do this and take this approach. So the included work is fairly recent. So we have had a lot of pushback, especially when people are just keen to get the numbers rather than look to see who is in the trial and who is missing. So we have had this issue quite a bit. So what we have been suggesting is that they use that in conjunction if possible, because even the census data, for example, it now has 19 different categories, but it's still othering a lot of groups. So it's still not as inclusive as it should be. So for example, in the UK, you have a category of British Asian. So under that, it'll be Asian or Asian British Indian, Asian or Asian British Pakistani. Similarly, you'll have it for Bangladeshi, and that's basically it. And then it's other. So what about the Chinese community, Korean community, Vietnamese, Thai, Sri Lankans? So a lot of Nepalis, for example, a lot of groups are left out. So for that particular study, what they did do was, that is something that they asked a lot of people from the community in order to develop it. And what they found was it wasn't that different. So one of the things we are currently in the process of doing is we collected data for particular participants for this qualitative research through an organization who helped us recruit. So we collected ethnicity data for these individuals from them. But during the interview, we asked people to self-describe as such. So there is some variation there, and that is something we are going to be writing up about in the qualitative study. So do watch the space. I appreciate that it's probably not the response that you were after, but it's still early days.
Can I ask a question of Dr. Dawson? If are there any other questions
Yeah,
in the queue right now?
no
Okay.
questions right now.
I'm curious just to kind of I know that Dr. Harrigan asked about the so the community champions, and I'm specifically curious about the training aspects. Is there sort of, are there sort of resources that one can look to in terms of providing these community champions with sort of an abridged sort of a course, so to speak, or some form of educational material on to bring them up to speed about research process, so that they can then disseminate that message within their communities? Just kind of curious to what's available.
So at Bristol, for the initial work with the health ambassadors, we, essentially tailored it according to their needs. So based on whatever they wanted and they requested, we offered it to them. So they all had some experience of research. And this is the other thing to bear in mind and remember as well. Quite a lot of people who work with these different community groups and organizations, some of them even have like a master's in public health, so it depends on what piques their interest. There are others who may not necessarily have that sort of knowledge or experience. So again, it's all thinking about tailoring it to their needs. That said and done, it's either Imperial or King's College London. They have developed some peer researcher training as such, which is freely available. I just need to find the link. Once I do, I'm happy to email it to you, and then feel free to share or cascade it if that works. So there is no standardized training or support available within the UK. So it's all like project to project really, and what we are able to offer as such. It'll be great if we can develop something that is like universal and that is standardized and that is systematic as such, so that we don't have to constantly keep reinventing the wheel, I suppose so.
Any other last minute questions for the few last minutes? I guess a question for Dr. Zhu. You kind of touched, and it was really interesting, on how ethnicity and race can affect like outcomes, and some like risk assessment scores that we use. Do you think that in the future we're going to be seeing more kind of I guess treatment duration, or I guess risk assessment models that are going to be using ethnicity and racial diversity to make treatment decisions?
No, thanks, Dr. Harrigan. I think it's a complicated topic in some ways, because I think, part of the challenge is the fact that, especially as it pertains to racial categorization, it is a very much of a social construct, and there is sort of significant heterogeneity in genetic diversity within racial categories. So, and especially in the in the context of racial sort of race adjustment, this has been the case for decades with respect to renal function adjustment, for example, that with recent research and has demonstrated that these are potentially contributing to a racial inequity with respect to for example, transplant eligibility or transplant timing, because of potentially false assumptions that were made about differences between racial categories. So I think the answer in some ways, and is not so much that we want to use racial categories as a covariate or as an adjuster, but thinking about some of the underlying mechanisms or some of the reasons why which these disparities exist, and then thinking about how well we can be more inclusive in terms of including individuals from racialized communities and from ethnic minority communities into research so that we have more generalizable predictors that actually perform equally as well among individuals who currently are underrepresented in research. So to answer your question, it's sort of really thinking not just as using race as a predictor, but thinking about the disparities as a starting point to explore further mechanisms, both biological and also importantly, socioeconomic as well.
Perfect. Any other last minute? Oh, Carol West here. Not a question, but a big thank you for an important and informative presentation. There's much to think about and to take away. Very lovely comment, and I think that echoes really this excellent seminar. Oh, screen sharing. Okay, perfect. All right, so with that, I want to thank Dr. Dawson, Dr. Zhu again. The recording will be made available on the CAN Vector website. Don't forget to fill out the evaluation and to tune in for our next seminar next month, looking at inflammasome signaling, thromboinflammation, and VTE. Thanks, everyone. Have a great day.
Thank you.